in China now is to replicate that, and all the indications are that that is on track, and people are doing well. But we need to know who has it. We also need to know who has it because that will protect us from the hospital outbreaks and the nursing home outbreaks that we are otherwise going to have. So that build of it sounds a bit silly, right? It's just a lab test. It's actually very, very complicated to develop a lab test in 3 weeks and to make it work. And so that to me is the big preparedness investment. And then the rest of it is about, for us hospitals, making sure that we protect our healthcare workers, that we maintain an adequate workforce so we can take care of sick patients, and for police, fire, TTC, hydro, all the people who maintain our essential services. It's about them dusting off their plans and thinking about things and making sure that we are prepared to go through a period of time when we might be short-staffed, but we still need to keep things functioning.
I want to add that the time is very important. I would say all the efforts in China and elsewhere trying to make public health control of the outbreak actually will give us lots of precious experience, and also for us to know the way how to react to this emergency. I think first, and we talked about the clinical stuff, about diagnosis. So we can learn a lot about in China what kind of testing toolkits work and how much it works, and also use a different diagnostic tools. And regarding treatment, I think we should not only look at the medication itself, we should look at treating the complications. Lots of people with diabetes, with COPD had got infected, and how to treat them and prevent the fatality rates, etc.
Yeah. Do we even really need to be fearful of COVID as it is? Because it seems that influenza has killed many scores more people, and yet we have free inoculations that we get, or free injections that a large majority of people aren't taking advantage of. So how should we really feel about this? Is the panic kind of warranted?
I think the relevant aphorism that there are still a great many uncertainties, and the applicable aphorism is hope for the best, prepare for the worst.
We had SARS, and our hospital, St. Michael's, was the SARS hospital. My secretary had gloves on, a mask on, a hat on, boots on, and a gown. Everybody in the hospital did. And we walked around all the time. I stepped outside and got on the subway, and everybody's hacking and coughing, so everybody's got to be aware. I don't know that. I think the answer is no. Yeah,
I have a question. Are we clear how the virus is spreading? How many ways the virus can be spreaded? Because it's a puzzle to me that we have identified several patients in Toronto, which taken the airplane here, but none of the passengers that around those specific patients got infected. The problem is that in China, just to take one patient on airplane or on the train, the viruses got spread everywhere. So
it's a great question. So I think we have to preface this with, we don't have all the answers.
Okay.
We're still learning more.
Okay.
So there's going to be some speculation in this.
Okay.
So if you're taking little media clips, don't just cut like a one-liner out. This is the full answer, which is nice to actually have a real conversation. So we don't have all the answers. We're humble and learning more, and there's some speculation in this answer. But if we take any respiratory virus that we know of, pound for pound, it's the people with symptoms that are more likely to transmit this infection to others. If you're coughing and febrile, have a fever, you're probably shedding more virus and you're spreading more virus to the area around you. That's not to say people without symptoms or mild symptoms can't transmit the infection. Just people with symptoms are more likely to do so. There's some good data looking at respiratory viruses and how they're transmitted on airplanes. And in many settings, you really look about 2 meters, a 2 meter radius around people, around an infected individual. Those are the most likely individuals who may get the infection. No guarantee. They may get the infection. There's a lot of variables that go into it. Is that sick person symptomatic? Are they coughing and coughing and coughing? So how much virus is coming out of that individual? The other variable is time, and a 45-minute flight from Toronto to Thunder Bay is a lot different than a 16-hour flight from Toronto to Beijing. So there's a few variables that may change the probability of transmission. But when we take a step back and look at the big picture, especially with this infection, we know that there's a large burden of people that were infected in Wuhan and Hubei province, and of course elsewhere in China. We know that there's a significant proportion of individuals who are not sick enough to reach that threshold of seeking health care. There's a term for that we use in medicine. We call it subclinical. Basically means you might have no symptoms, you might have mild symptoms, but you're just not there yet. You're not seeking health care because you're just not sick enough to seek health care. But if you still have this infection, some people might be shedding more virus, some people might be shedding less virus, but if you've got a decent population of people that are infected and are not isolated or identified by healthcare, and then isolated through either social isolation practices or putting on a mask or doing whatever it takes to prevent others from being infected, you're going to see a lot of transmission of this infection. And I think we saw that just ramp up rather quickly in Wuhan and Hubei province than elsewhere in China. And that's what we're seeing happening in different parts of the world as this virus gets imported to other places. So what I'm trying to say, short story long, is the rules are the same everywhere in the world. This virus is going to behave the same in an epidemic setting in Hubei province as it will in Ontario, as it will in parts of Iran where it is now. Like it's not going to change how it behaves, and I think a lot of how we respond to this virus from a clinical standpoint, from a public health standpoint, from a communication standpoint, from a bigger global perspective of changing how we're maintaining trade and maintaining transportation and I think that's really going to affect the outcomes rather than the virus behaving differently in different outcomes.
Yeah, one other thing. A piece of it is after, with the threat of multi-drug resistant tuberculosis and SARS on airplanes have actually done a lot to improve airflow. One other very important thing is that transmission of all viruses, and in truth, transmission of almost any communicable disease is person-to-person variable. Most people with an infection, for whatever reason, do not infect that many other people. Every once in a while, there's a person who is highly infectious. It's really frustrating. Most of the time, we don't understand why that's true. For some diseases, we know a bunch of things about it, like tuberculosis. But for respiratory viruses, for SARS, it really looked like a combination of things happening at one time. But what that means is you can have the reproductive ratio of this virus 2.5, okay? So that means on average, 2.5 new infections from the first infection. But it's not 2.5, if there's 4 of us, 5 of us in a line, okay? 4 of us are not going to transmit to anybody, and 1 person is going to transmit to 10 people. And so that means you can go, during SARS, Taiwan imported 13 cases and they did fine. And on their 14th case, they had 2 super spreading events in a row and they got into trouble. So it's not at all surprising that we've had a number of introductions in Canada that haven't gone anywhere. That's called good luck. Okay, we had bad luck during SARS. So far we're running lucky during COVID-19. Okay, so you do have to, you kind of have to look at the overall thing, not
We also
just
say good
at
public health.
individual cases.
Good luck and good public health?
Well, there's a lot of things that are good public health, but the absence, well, the case from Iran, that we haven't had secondary cases from the case from Iran, so that other than the case from Iran, who poor person had no reason to suspect that they had COVID, right? All of the other cases did exactly what they were supposed to do. They listened to it, they self-isolated at home, they called ahead when they got it. So that's good public health practice. The unfortunate person from Iran who had no reason to believe that they were infected with SARS-CoV, there's quite a lot of exposure from that person. And so far, we at least haven't identified any secondary cases. That's good luck.
I think the public education is very, very important because when we listen to this panel discussion, when I watch the WHO panels from the internet, people, experts talk about it in the expert language, very calm and very objective. But the rumors through the internet is really out of the question, it's totally wrong. And also the rumor and the fear spread far faster than the virus. So the China could contain the virus, but the rumors actually cannot be contained. So how can we educate the public then to make people feel more comfortable and more confident to learn something basic? I think that perhaps is very important.
I'm from the media, so when Toronto medical officer told me the first Ontario patient discharged, I feel relieved. But when I learned that this patient get well by himself, the disease has no curable medicine right now, I feel panic. I believe that the public panic, public fear relates to government transparency. Because on one side, the federal minister of health, and they told us in Canada the risk is extremely low. Now you tell me that the coronavirus come here, the COVID come here sooner or later. So I believe that right now we have 3 levels of government, federal, provincial, and also municipal. At the same time, public health department have 3 levels of departments too. So we as a media, we're running around for media conference from provincial, federal, and municipal. Can we all do it together, make it an authority body like the China? They have media conference every day, all right, from the authority telling the truth. The more truth from the government, the less panic from the public.
Point number 1, when you heard about this person recovering by themselves and there's no antiviral, I should remind everyone in the room, there's about 8 trillion respiratory viruses, and almost all of them don't have an individual pill that cures them. Influenza has a drug that we use to treat it, but for all the other, the list of respiratory viruses is longer than my arm. They don't have treatments. They don't. And the way you get better for them is the virus runs its course, your immune system kicks in, and you get better. And that's what happens. And that happens to the vast majority of these respiratory viruses. So that's point 1. People think we need a cure, we need a cure. We sure do. It would be really helpful. There's ongoing clinical trials. We will have data and answers shortly. But remember that most respiratory viruses, most viruses, forget respiratory viruses, don't have a dedicated antiviral drug to treat them. So that's point 1. You get better because your immune system, the virus runs its course and your immune system works. The second point is communication. Here's my bias. We've had now 10 cases in Canada. You can find messages directly from Dr. Theresa Tam on Twitter. She's holding press conferences. I think the openness and transparency at the federal, provincial, and city levels have been pretty remarkable. And even at the hospital levels, you hear hospital staff caring for individuals, giving press conferences. Dr. Jerome Lease is out in the parking lot of Sunnybrook Hospital telling everyone what's going on. This is pretty impressive communication in general. I'm not saying everyone, I'm not saying it's perfect, but if you take a step back and look at the communication about what's our approach, what's our plan, what's happening, how are these cases being managed? We started to hear from the federal ministers even before there were any imported cases. So, in general, I think the communication has been pretty remarkable, and it's not hard to find quality information if you're in Canada. I'm not saying it's all perfect, but I'm saying it's pretty darn good.
Just give you one example. A new case in BC, say it's learned that he's going to self-isolated at home. All right. So when you look at the other perspective from the public, say, does the Canadian hospital have negative room, have an isolated room to take care of this patient? Is it because there's no such facility in hospital, so that patient has to be staying at home? So that means that government has to say that which
What?
way.
I
So
don't
we
think
do have
so.
a facility, but it's better stay at home, it's isolation. Or we
No.
don't have.
That's not true.
I want
I don't agree.
to just tag on a little bit on that. We have, every kind of reactions from different levels of government have really to be done according to how this organizing these problems. We actually have 13 different health systems. So the Public Health Ontario organization is very different from the BC CDC, which is much more powerful and has lots more staff, etc. So I think one thing I would say that there have been coordinated efforts, but there are also some kind of missing gaps in the process. For example, how to support patients who are detected in the border control. Because I have seen, for example, examples people who were sick, having fever, and be detected by the border control, and then say, what should I do at home? They say, okay, that is a 911, 911, the telephone number, you just call them. So which is clearly not an optimal solution. So I think for the time we are now having, we should really look at what should be the different organizations at this moment, and then get coordinated efforts from not only from the medical point of view, but also from health system, public health point of view.